In this video, we describe an original elbow arthroscopic technique for coronoid process nonunion treatment. The patient is positioned in lateral decubitus on the operating table, the elbow placed at 100 degrees of flexion, while the forearm remains free with tourniquet is applied at the proximal limb. Using a superior anterolateral optical approach, an elbow anterior exploration is made. We confirm the coronoid process nonunion, we attest the posterior subluxation with the disengagement of the ulna under the humerus. A debridement of the coronoid fossa is made. Then the inferior part of the coronoid process is debrided with an electrocoagulation probe, and then with a shaver. Bone surface preparation is performed using a 4 mm motorized burr until visible bleeding is obtained on both sides. A 1/4 mm diameter threaded guide wire is inserted from the dorsal surface of the ulna to the center of the prepared nonunion site. A 2.7 mm diameter tunnel is then created using a cannulated drill over the guide wire, which is subsequently removed. A looped steel wire is passed through the cannulated drill and retrieved medially. A non-absorbable fiber wire number 2 suture is then shuttled through the cannulated drill using the looped wire, after which the drill is removed. A Scorpion automatic suture passer is used to pass the fiber wire suture from the deep surface of the coronoid to the superficial side, incorporating the anterior capsule, and then retrieved medially. A titanium button device is placed on the suture, which is then passed from the superficial to the deep surface of the coronoid process using the automatic suture passer, again incorporating the anterior capsule. Finally, a new looped steel wire is passed through the ulnar tunnel to retrieve the distal end of the fiber wire suture. The transosseous sutures are secured to a titanium button device. The elbow is positioned at 90 of flexion and the sutures are tied under tension over the button placed on the dorsal cortical surface of the ulna. The stability of the construct is then assessed using a probe. The patient is immobilized with a posterior brachio-antebrachiopalmar plaster splint for a duration of 6 weeks. Assisted active flexion extension rehabilitation is initiated at 6 weeks, while pronosupination exercises begin immediately. Strength recovery and manual activities are resumed at 3 months.